factor and CCP antibody. They may have typical erosions in the margins of their knuckle joints when x-rays are done. And that's very helpful sometimes for these patients because there are no drugs approved for joint treatment in scleroderma, but if you truly have rheumatoid arthritis, it opens a lot of different avenues for treatment, definitely in that direction. So x-rays are very helpful to get a baseline, and I'd like to assess what the structural aspect of the joints is like, especially the hands and wrists would be a good idea. But like I mentioned, early in the course of disease, very, very subtle manifestation, so we might not see a lot on the x-rays itself. But I'll go into details of what we can see on x-rays here. This is a patient who presented only with puffy hands and nothing else. In terms of skin manifestations, the pinch was still pretty good, but just a little puffy over the baseline with new onset of Raynaud over the last 1 year. And these hand x-rays are very helpful because this is not what I would see in patients with rheumatoid arthritis. In particular, you can see the arrow signs there, and there's this little chunk of calcium right over here in the knuckle, which is the calcinosis, and then you would start thinking about a possible connective tissue disease. It might not be scleroderma, it could be dermatomyositis, polymyositis, there are other connective tissue disease, but at least it makes you think in that direction of possible scleroderma spectrum disorder. So x-rays give you more information sometimes than we even think we'll get from them. This is another patient of mine who had much more florid disease. This was a 70-year-old gentleman with very long-standing scleroderma. So calcinosis can be very, very subtle. It can be very prominent and easily visible to everybody around. This was a nice study that studied hands in scleroderma, both from a clinical and radiological perspective. About 41 patients, 32 women and 9 men were studied with 26 of them having diffuse disease and 15 limited. And this is what they described in terms of the skeletal and joint involvement in the hand. And they termed it the sclerodermic hand, or called it the periarticular pattern in on hand x-rays. And if you see this, of course, you probably will see it on your exam as well. So loss of a lot of these terminal digits. One of my pictures is not popping up here. Let's see. So one of the pictures is missing for some reason. It's popping up here on my screen, but I can't see it there. But a lot of patients can have resorption of the terminal phalanges or the terminal parts of the digits, which make their fingers shorten over time. You can see that very evidently on the x-rays. You can see a lot of the calcinosis, and you can see that their hands are a little more bent than would be normal, because when you get x-rays, they ask you to stretch your hands as much as possible, and that's sometimes just not possible for a patient with scleroderma. So beyond the x-rays, there are modalities that are actually much more helpful to us than a simple clinical exam to tease out whether it is the joints, is it the skin, is it the tendons, or a combination of all these that is contributing to that puffy hand or inflamed joints. And not a lot of evidence or science or a lot of extensive studies to support this, but we do this in and out in clinical practice, and Dr. Molitor, and I can tell you how much more information we gain from musculoskeletal ultrasound as well as MRI studies of hand and wrist in these patients that pick up that soft tissue pathology so much better compared to x-rays. So these are studies, again, around 8 years ago. There was a study that showed a very limited number of scleroderma patients, but 17 patients were assessed with ultrasound, and they presented only with joint pain, were found to have inflammation in their tendon lining as well as joints in about 40% or more cases, and 6% with the joints. And another follow-up musculoskeletal ultrasound showed similar numbers or even more. But There were 8 patients who were examined with MRI, and all of them, 100%, had inflammation in the joints. Over 80% had inflammation in the tendons, swelling in the bone, as well as erosions that they were able to pick up on MRI. And I don't know how well this projects on the screen there, but you can see a few of those arrow signs there that are pointing towards the tendons. These are cross sections on MRIs, and you can see the very significant swelling and haziness around that tendon, which is concerning for inflammation in the tendon sheath, which can lead to a lot of swelling over the top of the hand. Similar swelling can be present in the tendons on the inside of the hand, which are called flexor tendons, and extensor tendons on the other side. You can see another view here on this next slide where there's intense white around the tendon. That's the contrast enhancement that the MRI demonstrates when there is a lot of inflammation within the tendons. This is a different view, and you can see here that this is the bone and this is the tendon. And you can see that intense white around the tendon, which is tenosynovitis, or inflammation around the tendon sheath. And this is a nice cut because it demonstrates both the joint lining as well as the tendon lining inflamed very prominently. And so it's a combination of synovitis and tenosynovitis in the same patient that's contributing to the manifestations. So this would be usually my approach to get a thorough history, do a good physical examination, assess the extent of joint involvement, and then consider x-rays because they definitely do give some information, if not a lot. But then consider in the right clinical setting ultrasound and potentially an MRI usually, which would give me much more information about the extent and severity. I would always get some inflammation markers at baseline to many of these are normal in some patients, but many patients also have significantly elevated SED rate and CRP, which are helpful to follow disease activity over time. I also do rheumatoid factor and CCP antibodies to see if there's an overlap syndrome, but as I talk to patients and they give me other symptoms, then I may expand my workup to include serologies for lupus or Sjogren's syndrome, or of course, important to keep in mind are scleroderma markers there as well. So I mentioned about the Cochin hand function scale earlier, and this is a self-administered questionnaire. How many of you have ever seen this before or filled one out? All right, so just a few in the audience who have some exposure to this in the past, but this is really the hand function assessment tool that gives you a broad idea about what the functional compromise is like, and it's really helpful for us to gauge this over time in terms of how well is our treatment doing, because there's not a lot of good treatments. But at the same time, is it worsening over time? Is it getting better over time? Functionally for the patient is important to address. And it's a very simple questionnaire that the patient can fill out in just a couple minutes, and it focuses on some basic activities of daily living that you do in the kitchen. So holding a bowl, raising a bottle, holding a plate of food, able to pour liquid out from a bottle into a glass, or unscrewing lids, cutting meat. You can see how challenging some of these activities have potentially been for you in your years with scleroderma. But similar activities in the setting of dressing, and then from a hygiene perspective, using squeezing a tube of toothpaste, or holding a toothbrush efficiently at the office, basic skills like writing or others such as opening doorknobs, cutting with the scissors, and so forth. And it's a 5-point scale, so right from no difficulty to the possibility of impossible to do that would be the gradations there. So coming to the most important part of this, the treatment approach. Again, we don't really have much to go by for this, so there's no treatment guidelines or therapeutic strategies that we can fall to look towards. But this was a nice study that they sent out surveys to 117 scleroderma experts and asked them how they would treat inflammatory polyarthritis in these patients, and about 43% of the physicians responded, and the biggest, the most prominent or popular choices as first-line treatments were methotrexate, in about 60% as the first-line medication. How many of you have had methotrexate treatment probably for joint and skin manifestations? So that's a really good drug that we often resort to where joint manifestations in particular are present at baseline, because mycophenolate mofetil is another very nice medication. We don't know how much it really works, but at the same time there's been a lot of benefit that has been seen for skin disease. On the other hand, it's very challenging for it to manage joint manifestations. So if there is joint and skin, we really like methotrexate as our first line. And in combination with that, often hydroxychloroquine, or also called Plaquenil, is a common one that is employed by a lot of physicians. And if people don't notice a lot of improvement within that 3 to 4 month mark, because that's usually a good time frame for these medications to demonstrate some efficacy, then often there's consideration to add a second-line medication, and a quarter of the physicians would also consider switching to a different medication. There's others that we'll go over in the subsequent slides that might be options. So this is a slide from Dr. Clement's paper from 2 years ago, and I think this is a very nice strategy that outlines some of that stepwise. And that first box on top, I think, is key, because pain management, which you'll definitely hear more about later in the talks today, is key to functioning and managing a lot of the symptoms patients have. But non-steroidals, where they can permissibly be used, of course, it's challenging with the GI and cardiac manifestations, so keep that in mind. But low-dose steroids, I like to keep it below 15 milligrams for most of my patients with diffuse skin disease, and definitely avoid using any doses higher than that for the risk of renal crisis. But you can be a little more judicious with our limited scleroderma patients. We can inject joints, so we can inject small, medium, and large joints with cortisone, and these are good strategies for a lot of patients for symptomatic relief, but of course they're temporary and very short lasting, so you could get 3 to 6 months of relief, maybe more than that, but they have to be periodically repeated. But you can see, you saw those MRIs, and can you see the number of joints and tendons that are impacted? We don't want to make you a pincushion, so we want to be very specific in which specific joints we can really help. So bigger joints for sure are very easy, but in the hands, it's important to keep in mind, can we inject a couple of knuckles that are most bothersome to the patient or could functionally help improve activity in them. Getting them into hand physical therapy and occupational therapy very, very early, especially the diffuse cutaneous patients, is key, because that time frame, the first 1 to 2 years, is where those contractures are going to develop, and unless we aggressively do something about maintaining the range of motion, we're going to lose the battle there. So keep that in mind. And then medications have their own small but definitely an important role. And depending on the type of x-ray, I think that there are strategies that one could resort to. So if you have features that are very much like rheumatoid arthritis, if you have erosive disease, then we think about methotrexate as our first-line medications, but there are other options to consider if patients have contraindications to those or don't respond to methotrexate at all. And the medications like leflunomide, it's a very, very similar medication to methotrexate, similar side effect and monitoring profile as well, with liver functions, and particularly that we want to keep in mind. There's combination therapy or triple therapy with hydroxychloroquine and sulfasalazine that can be added to methotrexate. This is a very common therapy that's used for rheumatoid arthritis patients, but can be very beneficial in scleroderma patients as well. You can use TNF inhibitors or medications like etanercept, also called Enbrel, Humira, Remicade. These are other medications that can be used as injections or infusions in the right setting, but much more beneficial for the patient that looks more like rheumatoid arthritis. On the other hand, there are strategies such as the little steroid under the 15 milligram dose. You can use medications like azathioprine or use infusions like rituximab that may be used for other components of the disease as well. But when you're trying to pick medications that can potentially help the lung as well as the skin as well as the joints all at the same time, then some of these are helpful. They're the mycophenolate as well as the rituximab in particular. There are many other new biologics that we might be seeing on the horizon. One called tocilizumab, another one called abatacept, which will probably see more data come out and hopefully some more solid recommendations, but still not ready for that yet. And then this is really what a scleroderma patient told me, and this is really the gist of the story. Motion is lotion. It's really important to keep actively going and just those low-grade exercises, the gentle stretching, range of motion, building endurance, and then using other complementary and integrated modalities, some of which you will probably hear about in the talks later today, are really key, because pain control and feeling good mentally is very important to maximize physical function. And no two people with scleroderma are the same, which is why it's very, very important to individualize some of these treatments and see who will benefit from both. Yoga may not be for you, but might really benefit another person. Similarly, medication, resilience techniques, Pilates, meditation, these are all right where you can potentially do it in your best interest. I get a lot of questions about diet and supplements, and again, I think there will be a big highlight on some of these things later in the talks, but there are some medications or supplements that have an anti-inflammatory benefits. There are studies from lupus patients as well as from patients with rheumatoid arthritis where we have some evidence to support their use. So omega-3, fish oils, turmeric are some of those supplements which can be taken. They usually tend to benefit from the higher doses which have been used in the clinical trials that study these supplements. But again, the quality and none of the supplements are really regulated at this standpoint by the FDA, so a little challenging to know how these new supplements might interact with the pre-existing medications that you're taking. So just keep in mind, a lot of these supplements may not be as benign as we sometimes think they are. So good to run it by your physicians, and a team-based approach with integrative medicine is probably most beneficial. And fatigue is really one of the more challenging aspects of the disease to manage, and I'm sure all of you have struggled with that. It's important to keep in mind a few things that can impact that, particularly sleep quality, having other aspects such as obstructive sleep apnea impairing that quality of sleep that you can get at night. Important to keep in mind. Do you have hypothyroidism, and with thyroid supplements help? Do you have vitamin D deficiency, and getting assessed for that and getting your stores built up, because some of that can really happen in this part of the world for sure. In our lovely winters, we definitely experience that big dip, so that impacts mood and ability to function, and so really, really, I think, important to keep in mind. And then at the end of the day, a little more about, the vascular component of this. So you know that, you're probably much more chilled and cold than any other person walking out on the street. And this morning was interesting as well. Already it's very, very cold, but this impacts a lot of that pain. And a lot of patients, of course, have the vasculopathy associated with Raynaud. So this is not simple Raynaud's. It doesn't just come and go. In between episodes, the blood vessels are still narrowed out. So this is what we would see on the cut section of a vessel in a patient who has advanced vasculopathy, and the blood has only that little space to go through. All the rest of it is completely blocked by the disease. There's just not enough supply to the peripheries, in particular the hands and feet. So important to keep them warm and keep your body temperature warm. But at the same time, sometimes when we talk about medications and patients come in with hand pain, a lot of that hand pain may be because the oxygen tension is just very low at baseline in between these Raynaud's episodes, and using vasodilators or medications to dilate the blood vessels and improve the flow in the hands might be very, very helpful to some of these patients in combination with managing their arthritis and tenosynovitis and fatigue. So briefly touching upon a few other components of disease, and I'll try to stay in my time limit. But myositis and myopathy are other important components of the disease, not as frequent, but can be very important and very debilitating in some patients. Usually it's a mild bland myopathy. Often in many scleroderma patients we would see a subtle escalation. Say that again?
Can you define myositis and
Yes.
myopathy?
Yes. So myositis is muscle inflammation, and myopathy is muscle weakness. So some patients just have a little bit of muscle weakness, others have inflammation driving that muscle weakness. And so when I say the bland myopathy, if you would take a muscle biopsy and look at it, there would not be a lot of inflammatory changes. But at the same time, myositis, there would be a lot of abnormalities on their muscle biopsies, and that sort of disease process is very important to assess a little better, as well as get a more solid diagnosis on tissue pathology so that we can know what to expect and treat it appropriately as well. So if patients have a little elevation in their muscle enzymes but do not feel weak on their physical examination, we just continue to observe, and usually a lot of that improves itself over time as we monitor labs going forward. But if they do exhibit weakness on exam, then we have to take it a step further, and there are tests that can make us understand where and which muscles are impacted. So this can be in the upper and lower extremities, usually the proximal muscle, so difficulty raising arms above the head, difficulty raising yourself up from the bot in the morning, climbing stairs, and so forth. Maybe some very early subtle signs, but even getting yourself up from the bed, rolling in the bed, some of those basic activities can get very significantly impacted if muscles are weak from an inflammatory process. And an electromyography or EMG nerve muscle conduction study would be a very uncomfortable but very important exam that helps us assess it better, and also helps us understand which muscles should be targeted if we were to pursue further workup with a muscle biopsy to understand this better. There's, just like rheumatoid arthritis, scleroderma can also have an overlap syndrome with polymyositis, and that is a completely different autoimmune condition with its own diagnostic or classification criteria and just a slightly different presentation, but largely that disease impacts muscles, and you can see patients with scleroderma who have an overlap syndrome with that. And there's some additional markers, big panels that can be sent out that can be very helpful, not only to understand their current disease process, but some of those markers have prognostic implications, so physicians often would resort to pursuing some tests like that. And then from a treatment perspective, many of these manifestations are treated very similarly. So myositis or inflammation within the muscles, as we talked about, would often be very responsive to methotrexate and azathioprine. Often mycophenolate mofetil is also used for this manifestation. So again, a large amount of this is directed by what else does the patient have. So we want to target multiple aspects with the same medication if possible. And you can use steroids often in a slightly higher dose, and this really depends on the patient's background and whether or not they have diffuse disease, where we are more judicious with using steroids up to 40 or 60 milligrams sometimes, but myositis can often require that. It can affect not only your proximal and proximal muscles in the upper and lower extremities, but if it starts affecting the muscles that you swallow with, you breathe with, that becomes a big challenge. And then we have to get more judicious with using not only steroids but other medications like rituximab infusions, or IVIG is a great medication for myositis that can be administered monthly on a periodic basis. And it's also helpful for patients who can't tolerate many other medications for other reasons, for reasons of infections in the background and so forth, but IVIG is very suitable in those circumstances. Very quickly touching upon tendinitis. Tendinitis is inflammation in the tendons, and this can be a very, it's relatively uncommon, but more of the profound features of scleroderma, where it's very unique to the condition, and something called a flexor tendon rub. This is, again, more of a physician term that we use, but there's a creaking, leathery, crepitus sort of feel when we move our hands over your joints, when you move the joints. It's just a very coarse, leathery feel that we can, sometimes you can even hear, but we can feel it on examination. And these are the various different sites in the body that you can feel it at. And this is really not seen in rheumatoid, not seen in lupus, not seen in majority of other conditions. So very unique to scleroderma, and it's a bad sign in a way, because that patient should definitely be started on medications as soon as possible. It carries a bad name and a bad prognosis in terms of affecting other organ systems, and so prevention is key there. The more aggressive you get with a management strategy, the better it is done earlier and as soon as possible. Flexion contractures are another aspect of the disease that can impact diffuse scleroderma patients in particular earlier during the course of the disease, particularly in the first 2 years. The clawing and curling of the hands that develops sometimes is just irreversible beyond that stage, and you can see when they're permanently bent, not only is it functionally debilitating, but it becomes a source of many, many other problems down the line. The skin is stretched out, it's thin, it's prone to ulceration, which is further prone to infection. The vascularity or the blood supply is very poor in some of these digits, and that's a setup for more problems down the line. So when you start developing those sort of skin changes, the ulceration associated with flexion contractures, that's when we start, when we really strongly think about surgical interventions. We don't otherwise like to perform surgeries on the extremities of patients with scleroderma, but this is one aspect where tendon and tissue release by the side of the contractures to help patients regain a little more function and straighten out that finger for recurrent problems to be minimized is helpful. And we want to try and avoid permanent hardware in these joints because, again, the vascularity is poor and there's more risk for infection developing. So often surgeons resort to fusing the joints. You can get an arthrodesis, that's the joint fusion. It limits function in a different way, so motion of that joint is completely gone, but it takes away pain, it prevents the infectious complications and so forth down the line. So out of 100 patients, maybe 2 or 3 would be a candidate for something like this. Coming to calcinosis, we briefly touched upon this earlier and saw some pictures, but another manifestation that affects 1 out of 5 patients with scleroderma, and it can be very localized and minor without any significant problems, but can be very, very significantly widespread. The problem is that it's the one manifestation of disease which nobody has found any good answers for so far. There's all these medications that have been trialed and not a lot are beneficial. So it still remains one of the hardest manifestations to treat, and again, prevention is the key. This tends to develop in those chronically inflamed avascular tissues where the blood supply is poor, so medications to improve the blood supply of the fingers in particular, and vasodilators are really helpful for preventing this progress in the long term. There's a very limited indication for surgery as well, because these things are notorious to come back. I don't know if any of you have ever had any surgical interventions to remove calcinatic deposits. Just by a show of hands, any of you have experienced that before? And in certain circumstances, it really becomes very important to get rid of this or reduce the burden, because you saw that picture of my patient. He had probably had at least 20 surgeries to remove these deposits from many, many different parts of the body, but each time they would come back. But there are small limited deposits, especially at the tips of the fingers, that are very prone to draining out, causing, you're going to use your hands, so it's going to get traumatized, it's going to get infected, and that's where the role of surgery to remove these small deposits comes into play. But keep in mind, again, the tendency to recur makes it very challenging. So to summarize, in the end, I'll end by saying that musculoskeletal manifestations are another important aspect of scleroderma and can be very common. Early diagnosis, thinking about scleroderma, in particular with patients who have joint issues, is important to get them in the right direction from a workup and management standpoint. There's better modalities to assess a lot of this involvement rather than x-rays, considering ultrasound or MRI exams before the workup would be very important, and treat that patient with the flexor tendon rubs as early as you can potentially get to treatment strategies, with surgery having a definite but very limited role in some of the patients that we take care of. Thank you very much, and happy to take questions. Yes.
Can the nail fold capillaries change over time, or do they just stay the same?
So the question is, do nail fold capillaries change over time, or do they stay same? So I wish I had brought along a few of those slides to tell you more about this, but there are gradations and subsets of nail fold capillary findings that are seen in patients with scleroderma. So of course there is a very limited subset that can have completely normal capillaries. These are some patients who may have a very, very early disease, which has not impacted a lot of their vasculature or other organ systems. Then there's the early, there's something called the early, active, and late staging of capillaroscopy patterns, and each is associated with prognostic implications. So early is usually earlier in the course of disease and has a better prognosis, where you see a lot of those capillary dilations developing. In the late stages, you have a lot of capillary breakdown, or something called microhemorrhages, where the blood is outside the capillaries. You see a lot of giant capillaries, reduction in the number of capillaries as well. And in the late stages, you can see a lot more damage, less microhemorrhages, but the capillaries have completely disappeared. They're just not there. And if you remember that picture on the right-hand corner of that slide, I don't know if I can go back. So here the whole capillary architecture is completely distorted. No, it doesn't at all look like the normal one, and this is part of that advanced late stage. There are studies that have shown that usually this progresses from the first stage to the next stage to the next stage as the disease progresses. So it really depends on which stage we're catching the patient on when we do the capillaroscopy, and each stage then has its own prognostic implication, as I mentioned. So from a diagnostic standpoint, it's very helpful as well as to assess what are the potential complications the patient can have. But there are stem cell transplant patients who have been treated, and there are some studies where there are some limited reports that have shown that the pattern can reverse. So from the advanced stages, a lot of those patients who were treated with myeloablative therapies, which basically made them restart that immune system all over again, were able to reverse to the early stages. But usually it's a one-way street, and we just don't have enough data right now on the nail fold video capillaroscopy to see if other patients just with medications like methotrexate or mycophenolate mofetil will reverse to the original patterns.
So is this something that your rheumatologist should check periodically?
So still a very important research tool, because we want to see how the vasculature gets affected. There are better tests to assess the lungs. There are tests that can be done like CT scans